Hi, my name is Melissa Werner. I am a nursing student in the master's program at Eastern Kentucky University. Today I'm going to present my poster on CBT, Cognitive Behavioral Therapy, interventions to reduce pediatric suicide. Suicide among adolescents is a major concern, not only for the community and our country, but for the medical professionals who treat those patients. One of the Office of Disease Prevention and Health Promotion, Healthy People's 2020 objectives is to reduce suicide attempts made by adolescents by 10% from 2009. During my research, the bodies of literature were consistent with the findings that therapeutic interventions such as CBT or other cognitive behavioral therapies like DBT and safety reduce the number of suicide attempts by adolescents versus treatment as usual. The population focus of adolescents were ages 12 to 18. The literature inclusion for studies was consistent with adolescents having a recent suicide attempt and had suicidal ideation not linked with cognitive dysfunction such as autism. The objective is to implement the CBT focused therapy in the outpatient setting. Then we can evaluate the effectiveness of that CBT therapy in reducing pediatric suicide and suicide attempts. This relates to my PICO question in children aged 12 to 18 who are at high risk for suicide. How does therapeutic interventions such as CBT, DBT, etc., compared to treatment as usual, affects attempts of self-harm within their school years? We would first screen patients in the outpatient setting with the National Institute of Mental Health Ask a Suicide Screening Tool, ASQ, which was created especially for younger patients 12 to 21. Once the patients are identified as candidates for CBT sessions, the guardians would be approached and give the opportunity for the children to participate. Those selected patients would have weekly sessions with the nurse practitioner and a CBT trained therapist. For the first 2 weeks, the treatment team, which would consist of the nurse practitioner, the therapist, and a case manager, they would meet daily to discuss any changes that needed to be made in therapy. Patients would be seen weekly for 5 months. At the end of those 5 months, patients again would be assessed with the ASQ screening tool, and the team would evaluate the effectiveness of the CBT. And the objective and the goal would be for the screening tool to be lower than it was when they were selected for the therapy. Finally, at the 1-year mark, again, those patients would have a follow-up and use the ASQ screening tool to see the long-term effects of the CBT therapy and how well it lasted. This proposed method of implementing CBT in the outpatient setting has promise, as seen with the literature reviews in random control trials. As the outpatient provider, they can follow up with the short and long-term effects of CBT to ensure the reduction in pediatric suicide and self-harm. Thank you. I also want to thank and acknowledge all my fellow peers who have helped me, the faculty at EKU, and the future team members of this project. Thanks.